Developmental disorders in the hospital OPD, in the unit of OPD. We also have an inpatient unit where children with neurodevelopmental disorders sometimes get admitted. And we also have projects both past and present that we both are involved with in autism and other developmental disorders as well. Yeah. So this is the unit of hope where we work, the Center for Children with Special Needs. Some disclosures and some acknowledgements to start off with. One is we don't have any financial relationships with any commercial entities, so our role today is purely as faculty from St. John's. Today as we talk, you'll hear stories of certain children who have developmental disorders, but we have changed all the names and identifying details. I'm very cognizant that today's audience, there are some parents and there are some professionals as well and some caregivers. So some of the stories that we say, and some of them will be clinical evidence, what the data says and what the science says. Some of it will be the children's and our experiences with them and their families. And some of them will be very hard truths as well. And what applies to one group of professionals might not apply to the other or to parents as well. But I think it's important, what we would want to do is to invite you to take what resonates with you and also try and see it from the other side as well, and this is an opportunity to do that. And finally, we do hope to learn as much from you as we share today, and we want to leave times for Q&A. And if things stretch beyond that, maybe in the lunch break as well. One note of apology is that when we sent out the Google form, we sent out this Google form and asked you guys, what are your expectations and what would you like us to cover? And we got a whole diverse range of answers and responses as well. We have tried our best to include as much as we can, given the time constraints. The things that we haven't included, so if you see something that you hope we would cover and you don't see it there, it isn't that that topic that you suggested wasn't important, it's just that in this time frame, that's all we could do, and we'll carry the conversation forward and also let you know how you can get in touch with us as well. So as you can see there on the slide, the distribution of the room here and the registered participants is most of you are from NGOs, organizations working with early intervention in children, and we have a good subset of parents as well. So these were some of the things in the form in terms of expectations from the workshop. Many people wanted things on assessment, psychoeducation of autism, types of interventions, rehab, how early can we detect, global developmental delay, muscular dystrophies, neuromuscular issues, comorbidities with autism, especially many of you had mentioned ADHD, the medical comorbidities as well, including epilepsy, family-centered care, life skills, functional independence as well, and quite a few, I think 8 of you had mentioned about assessments, what is the role of assessments and assessment reports in autism, some talking about complementary medications in autism, including diets in autism. So we have tried covering most of these as well, including some disability benefits, certifications, and other collaterals as well. Yeah, so these are what we hope to cover. Yeah, so with that, I'll hand over to Nelia, and Nelia will take you through NDD, GDD, and a little bit about cerebral palsy and DMD as well, and then I'll take it from there. Yeah.
Good morning, everyone. So happy to be here, and I think between Suhas and I, we're going to try and compress over 20 years experience into 2 hours. So we'll try and do our best, and we can discuss if you have any questions later. So I'm a developmental pediatrician, and there were questions on GDD. Neuromuscular, I'll be talking a little bit on CP and neuromuscular disorders. The most common, I don't know if you've heard of it, Duchenne's muscular dystrophy. Can I just see a show of hands, like how I'm sure the physiotherapists have worked with children with DMD. Can I see who all have worked with DMD? Right. Can we discuss a bit of DMD today? Because it is very common, and maybe you see it and you've not recognized it. So we'll have a little bit on DMD as well. Okay, so yeah, this is going to be my outline. I find this the most amazing organ, and I'm forever fascinated by it. And there was a quote that says, for humans at birth, the brain is remarkably unfinished, and interaction with the world is necessary to complete it. And we're all part of that world. And I feel today, speaking to early educators and therapists, like we literally hold these children's brains in our hands. And it's such a precious job that we've been given to do this, and it is such a privilege. Okay, so when does it start? This starts very early. Within 3 weeks, before the mom even knows she's pregnant, the brain has already started to develop. And it goes on, and at different times, there are different parts of the brain which is developing, and that's why when we see a child with delay, we take the antenatal history as well, because at different times, different insult to the brain will cause a different problem. Okay, so the brain keeps growing, keeps growing, keeps growing. Does it stop at 40 weeks when the baby is born? No, it continues. But one thing I'd like to point is that when a baby is born, one of the high risk conditions we have is when a baby is preterm. So if you see prematurity, let's say 28 weeks when the baby is born, his brain is still not fully developed. The last spurt happens in the last trimester, in those last few weeks. So that's why preterm babies should be kept on a high risk follow-up. Okay? And this is one of my favorite slides. I think I show it in almost every conference or workshop. It's just about neuroplasticity and how amazing this organ is and how it grows. So we all know sitting here that maximum brain development is in the first 2 years. Okay? So that's when the synapses are starting to connect with each other, and there are millions of connections happening every day. And in fact, a 2-year-old's brain has double the synapses of an adult. Because after that, what happens, the parts that they are not using or not required, they start getting pruned off. Okay, like how we prune our plants and our trees. We can't just let it grow, because if the whole tree grows, it's not going to bear fruit. So we cut off the parts that are not used, so it will be more fruitful. The same thing happens in our brains. If it just keeps growing and growing and growing with so many connections, we'll go crazy, because there's just too much information there. So the parts of the brain that are not used gets pruned off. Okay, so this is the neuroplasticity. Use it and grow it, or use it and lose it. Okay, and this is the whole basis of early intervention. This is why we're all sitting here today. Like one of the reasons, there are many. But early intervention is this magical period that we should harness. It is scientifically proven, it is evidence-based that maximum growth happens in these 2 years, and how we use this time is most important. If we do not use it well, that child will not develop in certain critical areas, especially vision, hearing, and language. Okay? So even different parts of the brain develop at different times. Okay, so if you see, initially, it's the vision and hearing. That's in the first 2 years. So that's very important to set the foundation of vision and hearing. Later, if we don't have the foundation, there's nothing to build on. Okay? And then as the child grows older, the school-going years, you can see there's a peak. When they're in preschool, actually, that's when the maximum peak is for learning. After that, it gradually declines. It does decline. And that's when the child is in about 10th standard, 11th standard, and getting into university. After that, it's mostly a decline. Okay? But not for everyone. I know there are people here whose brains are still very active. Okay. So what happens in autism? There are 2 things that can happen in the autistic brain. One is there's decreased connections. Okay? But on the other hand, that pruning is not happening, and there are just too many connections. It could go either way. And this is again to emphasize, the 90% of the child's brain development happens before 5. That little purple shade over there in the front, that's the frontal lobe for executive function. And this only develops around 21. That's why adolescents are also a little bit of a crazy group, because they think they're adults, but they're not really adults. Okay, so, but we need to understand that and work with them. Okay, so what is the importance of early detection? Autism can actually easily be diagnosed by 2 years. Okay, and I think we are doing it in Bangalore city. We are seeing children coming younger and younger to us because parents have picked it up. Sometimes it's a school, but that will be above 2 years. But we've got a lot of school children coming, like preschool, because teachers are picking it up. So, but the earliest is we can do it. I recently saw a couple that brought their 5-month-old baby, and the baby is their chief complaint was the baby is not sleeping. She's not sleeping. She's very irritable. She's not sleeping. Not sleeping. We went through everything together, talked about all the possible permutations and combinations like feeding and pain or fever or some deficiencies with me. And I shook the rattle and she looked at the rattle very happily. It was a green rattle. But she didn't look at my face and she didn't look at me and smile. Usually at 5 months, they're very excited if you work with 5-month-old babies. They look at you, they smile, they have their little giggles. But this little girl, she's very cute, absolutely adorable. But that eye contact was not there, that smile was not there. I asked the parents, does she laugh, when you talk to her? Then they said, yeah, when we lift her up and tickle her tummy, she laughs. But that's a different kind of laugh. That's an almost automatic laugh. But that laugh, that social smile, that responsiveness. So I'm not saying this child has ASD, but we're keeping her under very close observation. It could be other things. She could have a visual impairment. So first of all, we need to rule out sensory impairments like vision and hearing. If that little baby has a cataract, she won't be able to see. Okay? But one thing about this little baby, like I checked with the torch, there's no white reflex, but she's looking at the toy nicely, but she's not looking at me. It could be again something called cerebral visual impairment. Okay, so that's when the eye is normal, but the eye is just a place where the light passes through. The pictures, the messages are all formed in the brain. So there could be a processing disorder where she's not processing faces. But these are things we need to see, follow up, keep under close follow up and start early intervention for sure. Okay? So there can be subtle signs as early as 6 months. Maybe a baby who's had difficulty sleeping, maybe a baby who's having difficulty sucking. Some of them are very averse to breastfeeding. So some small signs are there. Do not wait and watch. That is what I want to say. Okay, because we all know early diagnosis leads to early intervention, which is better outcomes. And another main thing, I think it prevents the parents from running from pillar to post, going to one therapist and then to one doctor and then to sometimes they even go to the pediatric neurologist, and they're just going round in circles. So when we give a diagnosis, maybe we need to see. Sometimes a label is more harmful, but giving a diagnosis and starting intervention really prevents these parents from just running around and wasting valuable time. This is from a paper in Netherlands. 1 second. So this is about listening to parents. So this is like children with ASD. The minus is no ASD, this is no ASD. So this is the safe group. Okay, like there is no concern from the professional or the parent. This group is where there is concern from both. Okay, so it's taken seriously. Okay, the child has a problem also. This group, A and B, is a bit of a dangerous group because what happens is the professional has a concern, but the parents think nothing is wrong. And then we have the bad opposite. The parents come with a concern, but the professional, maybe the pediatrician, says, no, it's okay. We'll watch and wait. It's normal. Give him some more time to talk. Okay, these behaviors are okay. It's just a phase. So both these are both dangerous areas because we're missing. So also let's not ignore parents because they're with the children all the time. Any parental concern is also our concern. So some symptoms early symptoms, because I see younger children. So some of the, when we look back and take the history, we find that a lot of these kiddos had sleep problems even as infants. There were feeding issues, poor eye contact. Sometimes the only presentation is when they come around 18 months with a regression. Till then they were doing okay. Sometimes they come with speech delay. Sometimes they even come with a motor delay. And then we see that, oh, speech is also delayed. Poor imitation, poor pretend play, difficulty following commands, hypotonia, the restrictive repetitive behaviors. I think you all know all these symptoms, so I don't need to go through it. But sometimes you find parents who don't realize it's ASD or something is wrong, and they say, yeah, no, nothing's wrong with him. He responds when he feels like, when he's in the mood. And then you ask him, does he respond to name call? And they say, yeah. Then I say, okay, can you show me? And then they'll say, Rahul, Rahul, Rahul doesn't look. And then they say, Rahul, here, chocolate. And Rahul immediately looks. Sometimes parents think that is a response to name call. So don't always take their word for it. There are few things that you should try and elicit while that patient is with you. Okay? Language development, social communication. So a pediatrician may not be the first person this child comes to. It may be a therapist. It may be a psychologist. Okay? So the different points of entry for these children. Okay, this is just another graph showing what happens with early intervention. So when a child was compared to a child getting intervention at 3 years and 1 year, we look at the adult outcomes. A child who starts getting therapy from 1 year, this is his adult ASD severity. It's much more reduced than if he had started at 3 to 5 years. So while we are not even looking for the ASD diagnosis to go away. That's not our aim to like say, okay, now there's no ASD. However, we would like to reduce the symptom severity, and early intervention does that. Okay. Now I want to also talk about the spectrum. So I'm sure you've seen children on the spectrum. Some we may not even know they're on the spectrum, and some it's very obvious. So when we look at the diagnosis, each domain, verbal communication, non-verbal, social reciprocity, relationships, RRBs, intellectual ability, these all affect the severity, and the level of support. Okay, so someone who requires less support will have good verbal communication. Verbal and concrete. Social reciprocity may be there, inconsistent. There's some insight to social relationship. His RRBs are more thoughts and ideas rather than actually doing it. And he may be above average intelligence. As we go further down the spectrum, more severe, the child may be non-verbal. There may be non-verbal communication as well. Very little response. Social relationships, he's aware there's somebody else around but not really interested. And his RRBs are using his body. So rocking, spinning, pacing is his kind of RRBs. And his or hers intellectual disability will also be more profound. But there could be a mixture also across the spectrum. Okay, so it could be one from this side and another severity from the other side. It's not as simple as it looks. And our job is also to find what are these child's strengths. Okay, so autism is not a disease. I tell this to all my patients. It's a difference in the wiring of the brain. And we looked at the pictures of the brain and how brain development happens. There's a lot of factors that can affect brain development, mostly genetic, also environmental, and a lot of things that in the environment which affect the genes is what we call epigenetics. Okay, so there are multiple things at play. But it is not a disease, and they're just a different kind of human being neurodivergent. And our main aim as individuals, as therapists, as their caregivers is also to look for their strengths. So now what is GDD? How is GDD different from ASD? Can GDD and ASD be together? Okay. So when we talk about GDD, it is defined as a delay in 2 or more domains. So we look at development in domains. So you have your gross motor. Can anyone else tell me what are the rest? Fine motor, speech, excellent. Social, cognition, yeah. Language, yeah. So, social, thank you. So it all comes in domains. So some people will, if you think of a child with cerebral palsy, okay, Okay, cerebral palsy is by definition a motor problem. Okay, so think of some of the CP kids. Not all, again, depends on the severity of CP. When we think of CP, it's a motor delay. So what do you think will be the speech? If it's a GMFCS2? A speech. Speech may be?
When they talk,
Yes, there may be. What about cognition?
May or may not. Again,
On the
there's
mind.
people with good cognitive skills.
Exactly. What about social?
It depends. If the child has restriction of movement, not given exposure to interact with
Yes.
people, then there might be a social
Yeah.
interaction child.
Yeah.
But otherwise, for a child with cerebral palsy,
It is mostly motor.
yeah.
Yeah. And the rest depends on a lot on the community also and his accessibility. Okay. So when we think of autism, where is the delay? Which domains?
Social.
Yeah. Excellent.
Peer pressure sometimes.
Yes. Yes. If you think of a child with hearing impairment, only hearing impairment, where's the delay?
Speech.
Only speech, right? So we development is divided into domains. Okay, so when you have two or more domains which are affected, that's when we call it global developmental delay. So what are some of the causes? So we look at antenatal because GDD affects, which is the organ that's affected? Is it the legs in CP? Yes, but why are the legs affected? Because of the brain, right? So our brain is controlling everything. So causes of GDD. So it could be antenatal. These are some of the causes. So some of these GDDs go on to what, and we call them later ID, intellectual disability. Sometimes they just plateau. There's no further progression of milestones. Sometimes they regress. These two are a bit, if you ever see a patient who's not, like let's say it's a CP child, he's not attaining his milestones, because with neural maturation, there will be some improvement, despite what we do actually. Okay, but you see a child and he's labeled CP, but he's not getting better. Please think it's something else. Okay, it could actually be a genetic cause, like for example, I think ma'am has patients with hereditary spastic paraplegia. When we see there is no improvement, think of another cause. Sometimes, unfortunately, they develop and then they lose their milestones. This is always a red flag. If there's a child who is developing and then lost milestones, whether it is motor, whether it is speech, that is a cause of concern, because that is some progressive brain injury that is happening. Okay, so please refer these children as soon as you can. That should be a huge red flag. You don't again watch and wait. Yeah, so then if it's just GDD, like slow development, they're following their own curve and they are improving with time. Of course, with early intervention, this gap will be smaller, right? And that's what we're aiming for. So this is talking, we discussed this earlier, like the different domains, okay? So if in CP, mostly motor is affected. In ID, what will happen in ID? Cognition is affected. Okay, so it's again how to differentiate, because that again will affect our therapy. Okay, the slide didn't come out properly, I'm moving on. How do you calculate a developmental quotient? Have you seen these therapists? The DQ. So DQ is developmental age over the chronological age into 100. And we say there's a delay when the DQ is less than 70. Okay, do you know, and then if it's delay more than 2 domains, we call it GDD. So do you know why the 70 number came? Do you know this curve? It's not some random thing that we decided, okay, if your DQ is less than 70, I'm going to call you a delay. No, it's because of this, we looked at the entire population, and most people will fall between this 70 to 130. That is one standard deviation from the normal. Now, if the children's development is more than 2 standard deviations, see there are only fewer children here. That's when we start calling it a below average, and there's a delay. Okay, it goes the other way also. Like if the IQ is more than 130, then we say is high IQ, gifted, whatever. Okay, so that's how it is. It's all again in science. It's not random. Okay, so the factors, we talked about the factors in the first slide: prenatal, perinatal and postnatal. So that is what our history consists of. When we take the history, we start with the 3-degree pedigree chart. So we ask for, are they married within the family? Okay, because when you marry within the family, there's a higher risk of genetic problems. Does anybody know why? Do you want me to explain that? Yes.
The same way.
Okay, it's not the same, but yes, you're on the right track. It is, so we all have DNA, we all have genes, right? And we also have faulty genes. All of us are carrying faulty genes. But when 2 of those faulty genes come together, those are called autosomal recessive. If they come together, then the baby is going to have a problem. But these faulty genes, we all have. But if we're in the same family, we're having similar genes. So therefore, if those people get married, then there's a higher chance of those genes showing up. If you marry outside the community or very distant, it's actually good because they're brand new genes. Okay, and you probably get, I think, stronger kids also. Okay, that's just my opinion. But, yeah, I encourage to marry outside our communities because there's so much endogamy, and for the same gene pool is just going around and around and around. So there's higher risk of autosomal recessive disorders showing up. Okay, so when I take a history, it will start for 3 generations. So the child, the parents, hope is paramount, and when there's no hope, there's no future. And hope may at times be for a cure or a breakthrough in research, or for a maintenance of function. Maybe it's only a prayer for palliation, but there's always some hope. Okay, even for the kid where we think there's nothing we can do. If there's one thing we can do to make his quality of life better, maybe just improve his sleep, maybe just improve his diet, maybe just take away a little bit of his pain, maybe just play with him for a little while. There's hope in that. And we find wins in the small things, like he said his first word, he took his first step. For us, that's a big win, and we're here to share that win with the parents and with the community. Okay, so now the kid comes, we've diagnosed more than 2 domains, they're delayed. What do? So sometimes we do a couple of labs, laboratory investigations to rule out any deficiencies, see his hemoglobin, his thyroid function, because these are things we can treat. If there's a suspicion of epilepsy, we'll do an EEG. If the EEG is showing at a certain area there's a problem, we'll do an MRI. Nowadays, we have access to genetics, so we choose carefully because it's an expensive test, which child needs genetics. Okay, but in the South, with a high degree of consanguinity, we do it for quite a lot of our patients. Okay, then never forget hearing and vision screening, because those ones can appear like autism, and early intervention. So along with that, we're doing our early intervention. So what are the comorbidities of any child with GDD? Whether it's autism, whether it is CP, we look for behavioral problems, ADHD, self-injurious behavior, epilepsy. GER is a huge thing for children with CP. Malnutrition, both CP and ASD. CP because it's functionally, it might be difficult. ASD because of food fussiness, texture, sensory issues. Recurrent infections, constipation, sleep disturbance. CP, we see a lot of movement disorders, a lot of involuntary movement. So which side do we expect his? Left. So then later, we label the left hemiplegic CP. Now he has intellectual disability, he's got seizures, he has a visual impairment, and now behavioral issues, precocious puberty. That is like, now he's only 8, but he's already developing signs of puberty. Okay, so sometimes that happens in children with GDD and brain injury, and he also has obesity. So, and that cyst, we did an MRI for him. That cyst is still there, the shunt is a little bit displaced, and he's having seizures. And his behavioral issues have worsened, and now he's also got precocious puberty. Who can be the possible team members to help this boy and his family? Can I have your input? Okay, neurologist, then? Physio. Why? Okay, tell me why for each. Why neurologist, ma'am? Seizures. Yes. Okay, why physiotherapist, ma'am?
developmental.
Okay. But which part of developmental delay?
Physical movements.
Okay, he's got the right hemi. Okay, then who else? Psychologist, behavioral problems, very good. Then?
Ophthalmologist, because that's
Excellent. Don't forget the ophthalmologist because he's got visual impairment. Then?
endocrinologist.
Precocious puberty, endocrine, excellent. Then? Said.
And a dietitian for the obesity.
Dietitian. Then?
And the whole
Special
Special
education.
education.
Yeah. Okay, anybody else?
Parents and others have to
Parents.
follow regularly,
Counselors.
constant physiotherapy.
What are we doing? What else?
OT,
Yeah.
language.
So as you can see, we need so many people. And that's what we had actually we were so fortunate in St. John's we could do that. So, but don't forget that we need one more person, the neurosurgeon. We need a neurosurgeon also, right? We need so many people. So, but there's one more catch to this. This is a single mom. And she has rheumatoid arthritis, which further worsens her physical abilities. And she stays with her parents. So there's an elderly her parents, her mom and dad. So we sat down with the neurosurgeon, the pediatric surgeon, a child psychologist, our social worker, our vision, our ophthalmologist, our special educator, and we also included speech because we wanted to work on AAC for him. Okay, because that can also help a lot of the behavioral issues. If a child is able to communicate, things are so much better. And yes, endocrinologist for the precocious puberty. And we're trying to get an EEG done for him, but our little guy just doesn't sleep. So we'll be admitting him so we can get his EEG and the rest of this will come done. Okay, but this is the whole team that needs to be involved because otherwise, if I as a developmental pediatrician, I just control the seizures, that's just one small part of it. If the neurosurgeon puts a shunt, can drain the fluid in his brain that might be pressing on certain parts of his brain, which can also cause precocious puberty, which can also cause the seizures, which can also contribute to the behavioral issues. So, like maybe some of his issues will come down. Okay, but along with that, he needs to meet the therapist. Along with that, the parents, the mom needs so much support. And so it's, it is a multidisciplinary care because this is not a simple, straightforward case. And we should ask for help because we want to do what's best for that child, right? So where do we start? So that's how we started. We saw him, then we sat down. Then one of our fellows actually went to the school and saw how he was doing. Then we called the mom and the grandma, and then we had a chat with them. And yeah, it's an ongoing process. So yeah, these are the people for his care. There's physiotherapy, there it is. Okay. You have some energy for CP? Tell me honestly, if it's getting too much, I can run through it. Okay, we'll go through it quickly. CP. Okay, so CP is an umbrella term again. Okay. And then our favorite person once more. He has given us the latest definition of CP. It's a group of permanent disorders of movement and posture causing limitation of activity due to a non-progressive insult to a developing brain. Okay, so CP is just a one-time insult. Okay, that's why they get better. Okay, it's not an ongoing neurodegenerative disease. There's some diseases that are just progressive. We'll be talking about one of them. Okay, so it's associated with, these are the comorbidities. We've gone over through some of them. Okay, but we should also look for that when we see children with CP. I think I'll just discuss this with you quickly. 80% of CP is caused by something before the birth. Okay, only 10% is perinatal. Maybe before institutional deliveries, when there were more home deliveries, there would have been a lot more difficult deliveries, the child did not cry. But now with the advent of institutional deliveries, trained people in the field, most babies are getting the care they need. If that baby didn't cry, it was probably due to another cause. Okay? Okay, so early gestation is before 20 weeks, mid-trimester 20 to 34 weeks, peripartum is around the delivery time. So at different times, different injuries can have different complications. So if it's before 20 weeks, okay, so this is around the first, second trimester, the mother had a fever, okay, or the mother was taking some medicines. So what happens, this is when there's migration. If you remember the first slide, the brain is developing and it's not migrated to its final destination. So you get a gross brain anomaly. Okay, so it can be infection, hypoxia, genetic causes. So you'll have like microcephaly, you'll have anencephaly, lysencephaly, you'll have actually structural changes in the brain. If it happens mid-trimester, now look, this is 24 to 34 weeks. This is when our preterms are being born. So which part of the brain gets affected? The part of the brain which requires most oxygen. So this is around the periventricular area. This is the most vulnerable place at this time. Okay. So if there's an injury at this time, it will be in the periventricular area. So this is the periventricular area. Now, which area is affected? Can you see this? What is this?
The lower limbs are
Lower
affected.
limbs. Can you see the legs? Is it clear? Physiotherapist, this should ring with you.
More of the diplegia.
Exactly. So that's why in preterms you get diplegic when lower limbs are affected, because that's the area which is vulnerable. When the baby is around term and now there's birth asphyxia, now the place that requires most oxygen, most nutrients and metabolic activity is the basal ganglia. Okay, so the basal ganglia gets affected if it's term. Now what happens if the basal ganglia is affected? What kind of CP will we have?
More of dystonic or
Yeah, okay.
stenoid types.
Or the abnormal movements. Okay, so it also depends when the injury has occurred, right? So yeah, what I wanted to say again is only about 10% is due to pure birth asphyxia. So think about what else it could be.
But
Okay.
in our clinical practice now,
Yes.
we don't see that many children with cerebral palsy.
Ma'am, we have so many.
I don't know, in the community,
Every OPD I'm seeing kilos.
only in the community, in the villages we see more. City, I don't know.
Yeah, you're right, it has come down a lot. It's true. If you go to community, it's way more. And I think because of lack of knowledge, those are getting neglected also.
And the severity of the population we see in the community among the students is the severe ones, the very severe with the micro,
Yeah. Yeah.
seizures and other
Correct. Yeah. We need to go out to community. What we're seeing here is genetic causes actually. Yeah. Alright, so I'm not going to go into the examination because how many physiotherapists in the room? Can I see your hands up? Oh, how many occupational therapists? How many speech therapists? How many special educators? Wow, okay, that's our biggest group. Alright, but this is very important for you guys to know as well. Okay? How many parents?
Grandparents.
Oh, really?
Grandparents.
Wow.
That's all I
Okay, so this is when you should think other things. You know, there was no birth asphyxia, so is it CP? If there's only dystonia, is it CP? If there's a deteriorating course, is it CP? Diurnal variation. There are different reasons for this. If there's a family history of CP, do you think CP should be genetic if it's a one-time injury? No. But if you're getting a history that the brother also has, somebody else also has, think about a genetic cause. Okay, consanguinity again, think of a genetic. If there's dysmorphism, most of our CPs are not really dysmorphic. Over time, with the microcephaly and all, they may start looking, but they don't really have any dysmorphism. If there's a massive change in the GMFCS, okay, usually GMFCS doesn't change. Okay, I think this is too technical because there are only 3 physiotherapists here. Okay, again, regression. Anytime there's a regression, think of something else. Okay, yeah. Okay, so what I was saying is, sometimes if it's a metabolic problem, they can be treated. Okay? So if we're seeing something that's atypical, it could be something metabolic, and some of these metabolic disorders are very much treatable, especially to prevent a metabolic decompensation. Okay, so if you see something off, please refer the child. Okay, there are at least 54 treatable inborn errors of metabolism which mimic CP. So we shouldn't miss those ones because those are treatable. And again, if it's genetic, then we need to just think about the next baby and some counseling for the family. Okay, physiotherapists, what does this look like to you? These muscles are affected. Is this proximal or distal?
Proximal.
So proximal myopathy, what do we think of? Weakness in the proximal muscles. We can think of DMD. I want you to quickly take you through DMD because this is one of the progressive disorders. Okay, so there's a protein called dystrophin which is not produced, and dystrophin is required for healthy muscles. So then what happens, the muscles get damaged, and instead of muscle fiber, it's replaced by fat. Okay, so they get very hypertrophic calves. So if you see, sometimes we have a lot of children who come in, it looks like with ASD, but we find there's a motor delay. Just have a quick look at their legs. Okay, if you find there's a motor delay and you look at the legs and you see their calves are really bulky, we need to think of DMD. Okay, so for special educators as well. And when you see when this child wants to get up, he has this really strange way of getting up. It's like he's climbing up on himself. Can you see that? He'll put his hands on his thighs and slowly get up. Okay, so what is DMD? It's a progressive disorder whereby the muscles are progressively getting destroyed and new muscle is not being formed. So eventually they lose all ambulation. So initially there may be a developmental delay. It's mostly motor, and then slowly they lose all their skills, motor skills. Okay, so I wanted to talk to you about this. But I think, anyone here is a parent of a child with DMD? No. Then I think I'll skip this. It might be too much. But I'll tell you this because I think it's good to know. So this is a cell, right? Inside the cell, there's a nucleus. Inside the nucleus, you have chromosomes. Like if you're wondering, what is a chromosome? What is a gene? What is DNA? What are the differences? What is an exon? So I'll just quickly tell you what that is because a lot of parents will ask you, they may ask you these questions. Okay, so if you take the chromosome, it's all tightly wound, there are things in there, and you can, if you straighten it out like this, you get, what is this? The DNA, right? So what is a gene? A gene is a short segment of the DNA, and that specific thing will code for a protein, okay? So this is your gene. It may be 2 or 3 exons together will cause. So it depends. Now, when we talked about DMD, it's the largest gene in the human body because there's 79 of these DNA segments. Okay. So there's again, when it's so long, there's a chance for an error anywhere. And if there's an error in that, the wrong protein is formed, which is non-functional. This is how most genetic problems work. Okay, so like look at this. Can you read the first line for me? The cat ran down the hall. Now with just one difference here, what does it say? Wall. So that changes the way the DNA works and the protein that's produced. Oops, sorry. Okay, so if this is the DNA, one second. This is DNA. DNA codes to, translates to RNA. So now there's a defective thing here. Then that defective thing goes here. And then there's a dysfunctional protein that is produced. Okay, so one tiny spelling error, one tiny letter that changes will cause huge problems. So this is what normal muscle looks like. In the DMD child, the muscle is all very atrophied. But DMD doesn't just affect muscle, it affects the brain, the heart, lungs, bone, okay? know what X-linked means? Those who have seen DMD, do girls get DMD?
No problem.
It's just the
They're
boys.
carriers.
Correct, the girls are the carriers. Okay, and the boys will get the disease. But if you get a DMD patient, the mother is a carrier, please do screen the mother for any heart problems, because the dystrophin fiber is also found in the heart. And 1 in 2, like 50% of the mothers can have a cardiomyopathy. Okay, so what we do is we screen all the mums as well by doing an echocardiography. This is all management of DMD, which is again, can you see, just look at the people, there's so many people involved. It's also very multidisciplinary. And yes, I'm going to stop now. Thank you.